Welcome back. We know the topic of this video sounds somewhat daunting, but we will share some pointers about how to break down this evaluation into clear and logical steps. A handy reference we found are the current guidelines from the American Academy of Neurology. This keeps us evidence-based and ensures we've thought of the most critical alternative diagnoses from the differential list. This one-page document is an excellent summary of this topic and handy reference guide. A link to this page or reference tool can be found under the description of this video. Let's face it, this is a diagnosis no one wants to make, and there is an important differential list you need to work through. Research shows up to 20% of cases of cognitive complaints are reversible, so you want to be sure you find these patients. As we move along, we will review the main areas of any evaluation: history, physical exam, etc., with an eye towards leaving you confident you've covered the bases and made a correct diagnosis. As you start into the history of this problem, you want to think of three key elements. Get a clear pretest probability in your mind. How likely is dementia? Look for reversible causes. Of course, this is something you don't want to miss. And finally, since one of the key attributes of dementia is that it is a slowly progressing illness, look for things that cause more rapid changes, such as tumor or strokes. As you start to think about what the pretest probability of dementia is for a certain patient, start by thinking about what are the risk factors and whether they have a family history of the illness. Next, think about the onset of the illness. If this change in cognition has happened over years, and if it is slow in progression, chances are higher that it is Alzheimer's disease. If the cognitive symptom they are complaining of is memory-based, this is in favor of an Alzheimer's diagnosis. Also, ask about key accompanying symptoms, including emotional or personality changes, a medication history, other neurological symptoms that suggest stroke or TIA, gait and urinary changes. And finally, be sure you get one corroborating history from a family member or someone who knows them well. As we think about reversible cause, this is really important. The ones you want to make sure you look for are normal pressure hydrocephalus or NPH, depression, medications, and thyroid illness. For NPH, look specifically for gait changes. Typically, a patient's feet will seem stuck to the floor, frozen. Sometimes we call it a magnetic gait. They'll often have poor balance in general. Mild dementia changes and urinary incontinence round out the trio of symptoms that are NPH. For depression, you can use one of the depression scales. We talk about specific medications to look out for in a little bit. Thyroid disease is another of the more common reversible causes. When you are looking for causes of more rapid change in the history, you want to find out about any cancers that might lead to metastatic tumors. Most commonly, lung, breast, melanoma, colon, and kidney. Other rapid changes can come from stroke, so risk factors include the usual hypertension, diabetes. With AFib, think about people who are either new AFib patients or someone who is not consistently using their anticoagulation and so are more at risk for stroke. Find it useful to get part of the history from a family member or anyone who has knowledge on your patient and can give perspective on both how much change there has been and what impact this has been on function. Every once in a while, a patient will not allow us to speak to anyone, so we move on without this part of the history. We tend to focus more carefully on the objective evidence we get from the physical exam and cognitive assessment. Listed here are the key elements of the physical exam that relate to the differential diagnosis of memory loss. In general, we are looking for evidence of focal neurological deficits, cardiac disease, thyroid illness, and emotional disturbance. Cognitive assessment should be completed for each patient. If you did one of these during the screening process, you may not need to repeat it now. Be sure to choose the testing based on the patient's educational background. MMSE for patients with less than a high school education, and the MOCA for anyone who has completed high school. Let's now look at the diagnostic testing we need to do with labs and imaging. First, let's look at the blood tests. You may see a wide range of recommended and somewhat obscure blood tests, but evidence supports only those listed here as part of a routine dementia evaluation. Now let's talk about the role of brain imaging in a dementia evaluation. The cognitive assessment reflects the brain's functions, while the imaging shows the anatomy and any changes in the anatomy that could reflect the deficits that we identified in the cognitive assessment, or anything that is reported in the history as a functional decline. Whenever possible, an MRI of the brain without contrast is the preferred study. If there is a contraindication or the patient cannot tolerate even the open MRI, then a non-contrast head CT can be performed. As you are ordering the MRI or CAT scan, be sure to give the radiologist detail on the cognitive complaint or deficit you have identified. These days, they will often provide an estimate of the size of the different lobes of the brain that are associated with cognitive function. Though not diagnostic, atrophy in a certain part of the brain that correlates with the deficit will be another piece of information important in the overall evaluation. Putting it all together now, let's bullet point it out. If you have a patient with one clear evidence of change involving memory and one other cognitive domain that has come on slowly, and it now includes functional deficits, and you can find no evidence for one of the reversible causes, and you can find no evidence of other causes of slow onset cognitive change, then the diagnosis is probable Alzheimer's disease. Given the gravity of this diagnosis, it is really important to make sure we didn't miss any of the reversible causes. Lucky for us, there is an easy mnemonic that spells dementia. Keep in mind that D, drugs, the anticholinergics, are the most common cause. E, emotional. Remember that both depression and anxiety can be problematic. M, metabolic abnormalities. The most common is hyperthyroidism. Eyes and ears. E. Do not forget about vision disturbance and especially hearing loss. Increasingly, we are learning that chronic hearing loss is playing a role in cognitive decline. N is for normal pressure hydrocephalus. We've talked about the trio of magnetic gait, urinary incontinence, and cognitive impairment. T stands for tumor or other space-occupying lesions, which most often are via chronic subdural. I, for infection, brings in the possibility of HIV and syphilis in patients with the appropriate history. A reminds us to check for anemia, but also remember that alcohol intake can be related to vitamin deficiencies that can produce cognitive change. Finally, you want to be sure you have no evidence of any of the other slow onset cognitive changes. These would include vascular dementia, where the MRI is going to be very helpful, or emotional symptoms of depression and anxiety. Finally, Parkinson's disease with dementia or Lewy body dementia are two types of dementia that on a physical exam will demonstrate evidence of Parkinsonian features as the clue to their presence. In summary, if you find no other explanation for the symptoms and cognitive deficits that you've observed, then you should go ahead and diagnose probable Alzheimer's disease. Of course, no diagnosis of Alzheimer's can be 100%, but using these guidelines and making this careful search will mean you've been quite thorough in your evaluation. If you remain concerned, or because this is such a serious diagnosis, you may want to ask the patient and family to get a second opinion from a specialist. Before we finish, we want to leave you with some key pearls from Dr. Laird about when not to make a diagnosis of Alzheimer's disease. First of all, if the change has come rapidly, and by that we mean less than 6 months of change, be careful about making an Alzheimer's disease diagnosis. Next, if you don't have any evidence of short-term recall by testing or history, be careful of making that diagnosis just yet. Next, if the patient is taking one of the medications that may be contributing, remove the medication if possible and reevaluate in a few months. The most common medications include the anticholinergics, oxybutynin, and others for urinary incontinence are probably the most common. The common over-the-counter antihistamine, diphenhydramine or Benadryl, is often implicated. And finally, the novel antipsychotics, quetiapine and olanzapine. If a patient displays a lot of emotional symptoms such as depression and anxiety, try to stabilize them first from those symptoms and then reevaluate. And finally, if you have a patient whose cognitive change began with a delirium that was related to either a surgery or another acute illness, it's really important to follow them closely for resolution of the acute delirium and then evaluate them after 3 months. The fact that they had the delirium does correlate with an increased risk of Alzheimer's disease being diagnosed. You want to be sure that the delirium has completely cleared first. Completing an evaluation for memory loss is challenging, but we hoped you've seen that by following an evidence-based path for your patient's symptoms, your evaluation can lead you to an accurate diagnosis. Of course, your next task is perhaps even more difficult and even more important, and that is when you talk to your patient and family about the diagnosis. We will have more tips and pointers of that challenging time in the videos to come. Thank you for watching.